Why did the Frenchman only have one egg for breakfast? Because enough is enough. Folks, we're waiting just a few minutes to let people get on. We'll start in just a minute. Okay, well, good evening, everyone. Welcome to the CAPS Forum on Ethics and Public Policy. My name is Greg Jarrett. Good evening, everyone. Welcome to the CAPS Forum on Ethics and Public Policy. My name is Greg Jarrett. I represent the Walter H. Capps Center for the study of ethics, religion, and public life. I'd like to thank all the participating classes at UC Santa Barbara, including my own class, including some people from Religious Conceptions of Death, and some from the Medicine in Underserved Communities. I'd also like to welcome other people from the community, and I'd like to thank all the workers at the CAPS Center that have helped pull this off. And I'd like to thank and welcome all the heroic workers at Santa Barbara Cottage Hospital, Sansom Clinic, and others, and including volunteers here and across the world. Okay, so we have an action-packed week here at the CAPS Center. Before getting into tonight's discussion, I want to flag a couple of events we're doing this week. Tomorrow, we have an event called Subversives Gather. Now, if you don't know, Gather is a new documentary about the growing movement among Native Americans to reclaim their spiritual, political, and cultural identities through food sovereignty, which includes things like reclaiming salmon and buffalo and wild rice and all kinds. It's fascinating. Our event will not be a screening of that show. However, registering for the event does come with a link to view the documentary. It's also available on Apple TV if you prefer to pay. Now, our event, Subversives Gather, is actually a conversation with the director and the editor of that film, along with our own Greg Johnson. That's tomorrow, Tuesday, March 2nd, 4 p.m. Pacific time. Now, next Thursday, we have another installment of our Ethics in Place Symposium, and it's called Implementing the United Nations Declaration on the Rights of Indigenous Peoples. That's Thursday, March 4th, 4 p.m. Pacific time. We put in the chat the information, the links to these things, or you can go to the CAPS Center page or our Facebook page to register on Zoom. Okay, at this point, I'd like to invite Dr. Cohn to join us. In 2019, there she is. In 2019, I approached the CAPS Center about inviting Dr. Cohn up to Santa Barbara to do something to honor the 50th anniversary or whatever of Elizabeth Kubler-Ross's On Death and Dying. And then suddenly 2020 happened. And here we are a good deal later, but we're thrilled to finally have Dr. Cohn up to virtual sunny Sandy Barbara. Now, Dr. Cohn specializes in proactive ethics intervention especially in intensive care units. She's the bioethics director at Kaiser Permanente, Orange County. She's associate adjunct professor at UC Irvine School of Medicine, and she's written numerous articles, some of which I use in my own class in bioethics, and co-authored several books, including The Ethics of Bioethics, Mapping the Moral Language. So tonight, we're delighted to have Dr. Felicia Cohn. Her talk, of course, is called Death, Dying, and Medical Ethics in a Time of COVID. This is when we usually have a round of applause, but I think I'll just disappear and hand things over to you, Dr. Cohn.
Great, thank you, Dr. Jarrett. It's so nice to be with you all. I wish I could actually be with you all. We'll have to save that for another time. I've always wanted to see UCSB, so maybe one day. I am here tonight to talk about death, dying, and medical ethics in a time of COVID. So we can jump right in. I think there is a provision for questions, if should you have them. I think, just put them in the chat and they'll be collected and given to me at some point. I want to say a little bit about myself. I've been doing research, teaching, and real-life ethics consultation in death and dying issues for far longer than I care to admit, but well over 25 years now. And some of what I'm going to talk about tonight comes from that experience. So the next slide. The objectives tonight are to think about the myths and reality of dying, explore how dying has changed over time, and understand the opportunity for advanced care planning that the context of dying in the United States gives us. Next slide, please. So I want to start with where things are, sort of a cultural reality check. And I don't know if any of you all remember this gentleman, Cardinal Bernardine. He died in 1996. Before he died, he was diagnosed with cancer. And rather than being depressed and morbid and retreating with that diagnosis, he decided to use it as a teachable moment. And he really wanted to share with people what meaningful life while dying could look like. So really teaching us how to die. But I thought it was really interesting that the same week that this Newsweek cover appeared on the newsstand, next slide, please, so did this Time magazine. And I have to admit that even though I was deeply immersed in end-of-life research at that point, if I was at the newsstand looking for something to read on a long flight or a sunny afternoon outside at the beach, I would be more drawn to this magazine cover. And I suspect that was probably true for a lot of people. This is where our culture really is. We are searching for that, a fountain of youth, immortality, ways to keep us forever young. Next slide, please. And this is where I really think the societal disconnect comes in. Last time I checked, the mortality rate remained 100%. No one gets out of this life alive. And yet we see death as something to fight. And you see this, if you drive along the freeway down around LA, you'll see these signs for USC, no matter what, fight on. And that is not an unusual expression or motto for a lot of hospitals, a lot of medical centers. And then, this was another favorite magazine cover, came out a number of years ago. Can Google solve death? And they noted they were going to put some of their best researchers on trying to solve this problem. Why do people have to die? And then Ian Morrison, the former president of the Institute for the Future, noted the Scots see death as imminent, Canadians see death as inevitable, and Californians see death as optional. Americans and the American healthcare system are uncomfortable with the inevitability of mortality. And I was always captured by that quote, the death as optional. I think it actually is well beyond California. I think that's part of our American ethic, that it's something to be defeated, something to fight, something to try to overcome, although we have not been successful yet. Next slide. So this is what death has come to look like because of that entrenched motto. Natural death has come to mean ICU death, where we are bound in hospital beds to lots of machines using technology, medications to keep us alive. And we make fun of it. We make light of it. Hey, I think he just moved, add one more, keep people tied down and tethered to that technology. Try to get some rest. I'll be in every few minutes to make sure you don't, which is a common complaint among hospitalized patients, but is the reality. There's so much poking and prodding and turning and medication checks and everything else that goes along with being in the hospital, that this is what dying, fighting to live looks like. Next. Because dying has really become prohibited. We consider it a failure. And even the language that we use, the metaphors we use, that metaphor of battle, that metaphor of fighting, that it is a defeat when someone does die. We take those to heart and feel like we have to continue the fight. Next. So I want to remind you of one of my favorite books. I don't know if you all had to read this in high school or maybe in college. Jonathan Swift's Gulliver's Travels. And this is not his most famous story. This is not the Lilliputians. There was another land in his book called Lucknow. And in this land, there were people called Struldbrugs. And these folks were immortal. So he satirized what immortality might look like. Now, keep in mind, he was writing back in the early 1700s, and yet he's had similar conclusions about how we feel about mortality, even way back then, when death was not so optional. We didn't have the treatments that we have now. But he wrote, "Happy nation where every child hath at least a chance for being immortal. Happy people who enjoy so many living examples of ancient virtue and have masters ready to instruct them in the wisdom of all former ages. But happiest beyond all comparison are those excellent Strudelbrugs who, being born exempt from that universal calamity of human nature, have their minds free and disengaged without the weight and depression of spirits caused by the continual apprehensions of death." So Gulliver thought, if I were king in this land, I would surround myself with these immortals. Think of the wisdom, think of how much I could learn, think of the mistakes that could be avoided if I shared in the wisdom that these people have from having lived for so long, until he met one. Next slide. "They were the most mortifying sight I ever beheld, and the women more horrible than the men. Beside the usual deformities in extreme old age, they acquired an additional ghastliness in proportion to their number of years, which is not to be described." So what Gulliver had forgotten is that while they would never die, they continued to age and experienced all of the other conditions that come with aging. They would become frail, they might lose their memories, they might be unable to do a lot of things for themselves. He went on to talk about legal implications of this in this time. And remember, way back then, living to your 40s made you elderly. But back then, these folks, when they were 80, when they got to that point, they were basically considered to be dead. They were treated as if they were dead. They were not given, well, their possessions were taken from them and distributed as an inheritance. Their legal rights were taken away. They were basically treated as if they no longer existed. Next slide. So what did he learn from this? The reader will easily believe that from what I had heard and seen, my keen appetite for perpetuity of life was much abated. I grew heartily ashamed of the pleasing visions I had formed, and thought no tyrant could invent a death into which I would not run with pleasure from such a life. The king heard of all that had passed between me and my friends upon this occasion, and rallied me very pleasantly, wishing I could send a couple of Strudelbrugs to my own country to arm our people against the fear of death. But this, it seems, is forbidden by the fundamental laws of the kingdom, or else I should have been well content with the trouble and expense of transporting them. So ultimately, Gulliver learned that there may in fact be something worse than death. Next slide. And I think this lesson is something we need to take heart today, that immortality does not mean eternal youth and health, that we need to recognize the effects that aging have on all of us. Because ultimately, the only thing that stops the aging process is disease, illness, and ultimately death. So do you have anything that stops the aging process? Sure. What kind of disease would you like? That is the double-edged sword to our extended mortality now. That in the past, we would die very differently, quickly, without the medications and treatments and technologies that keep us alive now. We would be doomed to die slowly over time of some chronic, progressive, eventually fatal condition. Next slide. So how do we die? Things have really changed a lot over the last 100 or so years. In 1900, the average age at death was 46. Now it is about 78. It actually has gone down just a little bit over the last year, probably COVID related. So now it's actually a little over 77. If you're a woman, you're more likely to live closer to 80. Man, a little younger, a little earlier than that. If you make it to 65, you're probably going to make it into your 80s. The causes of death have changed significantly over the last 100 years. Used to be, we would die of infection. Remember, there was no penicillin to treat anyone with. We died from accidents, and a lot of women died in childbirth. Now we're more likely to die of these chronic progressive illnesses: cancer, organ system failure, stroke, or dementia. Disability didn't used to really be a thing. We died too quickly to experience much time with disability. Now we are likely to experience disability for 2 to 4 years before death. And financing has changed a great deal. Healthcare didn't used to cost very much. Those expenses were usually borne privately. They were very modest. Now, as we are all aware, they are public and quite substantial. Medicare alone was over $800 billion in 2019. The proportion of that spent on end-of-life care is significant and growing. Medicare and healthcare costs overall are becoming a dominant portion of our gross national product. Next slide. So I want to look at these trajectories of dying, how it's become more complex and over time. And this is just a visual depiction of what I was just talking about. We used to become ill and we would die fairly quickly after that. Now we can become ill and live for a significant period of time before we finally do pass away. Next. But I want to look in more particularity about what those trajectories toward death actually look like, and then talk about the implications of this for healthcare. So cancer is probably the most recognized path to dying, the one that we think everything else should look like or does look like. And with cancer, if you are not cured, you can still live with cancer for a very long time at a very high functional level. You are still going to work, you may still be taking care of your children, driving carpool, making dinner, whatever else is you do, until you get to a point when you are sicker. That is a noticeable point when you begin this precipitous decline. This is the point where others might suggest you be enrolled in hospice, where we might really recognize that you are dying, where doctors feel comfortable saying you have a prognosis of 6 months or less to live. And usually within about 2 months, you will pass away. Again, if you're not able to be cured of your cancer. And this is actually about the way about 1/5 of us will die from cancer, but the other illness trajectories are much less clear, less easily predicted. Next slide. Organ system failure. This would mean heart failure, lung failure, liver failure. These kinds of illnesses, we can still also live for a long time with medical treatment, but we're probably at a much lower functional level. Your heart's not working as well, so you get short of breath. Your lungs are failing, so you require oxygen. Maybe your kidneys have failed, you have to go to dialysis. Your liver's failing, we can't fix that. But we do get sicker. We go to the hospital. You see these dips, these exacerbations in our illnesses. We go to the hospital, they fix us up, we bounce back. Not quite as good as we were before, but okay. And this can happen over and over and over again until one day we go to the hospital and that is our last trip to the hospital. But we can't predict when that is. And it always feels like a surprise. And the families I work with who have loved ones with these kinds of illnesses always tell me that it seems so sudden. And I'll ask them, you knew he had congestive heart failure. He's been sick for years, but I just had lunch with him last week and he was fine. So it always seems like a sudden death, even though we could have anticipated within a few years that this person was probably not going to last. Next. And a third and common trajectory, this would be dementia or physical frailty. So just sort of that gradual running down of our bodies. So what Gulliver saw, that as we age, we experience these things that just make us weaker and less capable. So with these kinds of conditions, we are usually older, 80s, 90s, sometimes younger, but usually older. And our functional level is much lower. And we can persist like that for a long time. Again, maybe going back and forth to the hospital, maybe we need a little more assistance, maybe we need a wheelchair, maybe a feeding tube to help us survive. And this can last for 6, 8, I've seen people with dementia for 10 years, until finally our body just gives out. And this also feels surprising. Even though we knew this individual was sick, we knew they were declining, it still is not predictable. We don't know when that last day is going to be, that last trip to the hospital, or that last time they go to bed and just don't wake up. Next. So here's what happens. Now this is data from the support study, which is several decades old now, but it hasn't been replicated. So it's still helpful, and I think still reflects the way we prognosticate. So I'll preface this by saying physicians are known to be notoriously bad at prognosticating, that is, predicting when someone's going to die. And this study has really borne this out, but I think it really traces back to those different kinds of trajectories and how they can trick us into not recognizing when someone is really dying. So if you consider those trajectories I talked about, let's start with that bottom orange line. This is a patient with lung cancer. So a week before this patient died, we looked at the data, we asked these questions every day and then looked at the data and retrospectively looked back a week before the patient died. And at that point, physicians were predicting that a lung cancer patient had about a 50-50 chance to live for another 2 months. The day before the lung cancer patient died, they had gotten a little better, and this patient had less than a 20% chance to survive for another 2 months. But then when you look at the congestive heart failure patient, so this would be the organ failure trajectory, it was trickier. So a week before death, this patient had about an 80% chance to live another 2 months. And even the day before death, the physicians had predicted about a 70% chance that this person would continue living another 2 months. So that's why it can feel surprising when someone dies. So these patients, the lung cancer patient that week before death may be recommended for hospice. Maybe start getting comfort care, maybe is getting all the resources that we associate with end-of-life care. The congestive heart failure patient probably isn't, because we don't really recognize that he is actually dying. Next. So this is why we've come to rely on hospitals. We believe when the patient goes to the hospital that we can continue rescuing, that we can defeat death, that we can continue treating this person. And this is what death has come to look like, even though 80% of us in polls have said we want to avoid hospitals and ICUs during the final phase of illness. We all want to die at home. These days, about 35% die in hospitals, 31% die in nursing facilities, and 27% die at home. And I want to point out here, you see the physician standing over next to the patient lying in that bed saying, please let me die. And we are doing everything for him. We are breathing for him. We are providing blood. We are pumping his heart. We are inflating his lungs. We are making sure his liver is working. We are making sure his kidneys are functioning. That's what all those machines are. And this patient has had enough. Please let me die. And the response from the physician is, what? And play God? Now, I don't actually hear that much from physicians, but I do hear that a lot from families. They don't want to withdraw life-sustaining treatment because they feel like that would be playing God. And in a way, they are right. But I think what they miss there is that we already are. We are doing all of these things. We are interfering with God's plan, or whatever higher power you believe in, whatever forces keep us alive. We are interfering with natural death by doing all these things that the patient can no longer do for himself, and often will never be able to do for himself ever again. We are already playing God, interfering with that natural plan, interfering with a patient who would have already passed away if we hadn't provided these things. Next. So it always raises for me that question, is more better? At what point do benefit and quantity collide? When do benefits decline? When is quantity no longer worthwhile? People talk about quality of life and balancing that against quantity of life and deciding which is more important for a particular patient and for a particular family member when you're making decisions for them. And that's not a question I can answer because everybody has a different point. But at some point, I do think we meet that law of diminishing returns, where what we're doing isn't really helping anymore. We are not defeating death. We are not prolonging life. We are merely prolonging dying. Next. I'll note too, this article came out and I was so taken with it because it reflected what I had already been seeing, that doctors die differently. It's not a frequent topic of discussion, but doctors die too. And they don't die like the rest of us. What's unusual about them is not how much treatment they get compared to most Americans, but how little. For all the time they spend fending off the deaths of others, they tend to be fairly serene when faced with death themselves. They know exactly what is going to happen, they know the choices, and they generally have access to any sort of medical care they could want, but they go gently. Of course, doctors don't want to die, they want to live, but they know enough about modern medicine to know its limits, and they know enough about death to know what all people fear most, dying in pain and dying alone. They've talked about this with their families. They want to be sure when the time comes that no heroic measures will happen, that they will never experience during their last moments on earth someone breaking their ribs in an attempt to resuscitate them with CPR. That's what happens if CPR is done right. And I have seen this. Doctors in my hospital, doctors I've worked with in my hospital, and they do tend to refuse more treatment than other people. I will note, however, that that is not the case for their families. When a family member of a physician is in the hospital, they will advocate for and push for as much treatment as the rest of us do, fearful of losing their loved one. Next slide. So I wanted to figure out what all this means in the context of COVID. When the pandemic first started, when we were first seeing the big surge of patients in our hospitals back in March and April, the families were much more accepting of death. The media had done a good job of scaring us all with how serious this disease could be. And we had heard in the news that once you ended up in an ICU, that once you needed a breathing machine, a ventilator, that you probably weren't going to make it. Families knew this. And when their loved ones were intubated, when they needed that tube to help them breathe, families recognized that this is not good and that the outcome might be bad. And they were much more cooperative when the physicians recommended changing the code status from full code to do not resuscitate. They agreed when physicians said, this isn't helping, we need to stop. But then that changed. And a few months later, as there were more treatments, when there was remdesivir and convalescent plasma and probably a number of other things you heard about in the news, families started asking for more. And COVID deaths came to look a lot more like all of the other kinds of deaths I've seen in the hospital. So for scientists, death isn't a divine decree. It is merely a technical problem. Humans die not because God said so, but because of some technical glitch. Will the current pandemic change human attitudes to death? Probably not, just the opposite. COVID-19 will probably cause us only to double our efforts to protect human lives. For the dominant cultural reaction to COVID-19 isn't resignation, it's a mixture of outrage and hope. And that, I think, is what I saw. That families would no longer accept, and the physicians would no longer accept, that a patient would die from COVID. There was more we could do. We had to keep pushing, had to keep fighting. Next. So that has changed some attitudes, though. I think more of us are thinking about our mortality because it has been in our face for a year now. So more of us are thinking about what that would mean for us. What would it look like if I were in the hospital? What would I want to have done? At what point would I say no more? Would I ever say no more? But about 85% of us still aren't ready to start a conversation about it. We're still not talking to our families about what we would want. 70% have not made end-of-life plans. 63% of those in the baby boomer generation are without an end-of-life plan. And those are some of the patients who are most at risk, at least right now. Over 60% of millennials report talking about end-of-life matters with their families, and that's probably the largest shift. So maybe it's a generational change. Next. Making your wishes known. So 97% of people say it's really important to talk about their wishes and put them in writing. 37% have actually done it. And I'm still not sure why there's this huge disconnect. Next. There have been a lot of laws to support our ability to do this, to make choices and to document those choices and to have those choices respected. You know, back in 1991, as a result of some pretty high-profile court cases, a federal law was passed, the Patient Self-Determination Act. And this law allowed patients the right to accept and refuse treatment. It also upholds the right to create advanced directives. And I'll talk more about that in a minute. States followed suit. In California in 2000, the California Healthcare Decisions Law was passed, and this law includes an advanced healthcare directive. And then in 2009, we went one step further and actually moved from statements of preferences to creating a law that allowed for a medical order, the California Post Law, or the Physician Orders for Life-Sustaining Treatment Law. Next. So what is an advanced healthcare directive? Well, this is your opportunity to make your wishes known. And people see this as depressing, as a discussion about death. I would argue it's a discussion about choice. And that is something we as Americans value, probably way too much, but choice, the ability to have the freedom to make choices, to make our wishes known and to have them respected is really important to all of us. And the Advanced Healthcare Directive allows us to do that when we are in a situation when we can't otherwise speak for ourselves. So the Advanced Healthcare Directive, or Advanced Directive for short, is a legal form completed by a California resident. Really, there are these forms in every state in the country, and most states do recognize those from other states. But it allows a resident of at least 18 years of age, so you have to be an adult and of sound mind, to determine who will make healthcare decisions for them and their desires and beliefs about treatment and your beliefs about organ donation. So this is a document in which you get to choose who will speak for you when you can no longer speak for yourself. So you get to decide who is going to best represent my wishes. What is it I want and who's willing, who do I trust to make sure that that is what happens? So if I want to try to live forever, if I want every treatment, whether the doctors think it's going to be helpful or not, I need to find someone who is willing to say that and go to bat for me. If I want not to be treated, if there are some things I don't want, if there are conditions I consider worse than death, I need to find someone to represent that as well. And that means choosing very carefully. Unfortunately, I see most people just default to their spouse or a parent or an adult child because that's their next of kin. And these people don't always know what you want unless you've told them. And I found the first time I went to go do my advance directive, I wasn't married yet. I was relatively young, and I went to my parents. And I thought, it's going to be my mother. My mother was an accountant. She dealt in cold, hard facts. That's what she lived her life by. She was not terribly sentimental. And I thought, she's going to be the person to make decisions for me. She will hear what the doctors say. She will look at the facts. She will think about what I've told her is important to me and make a decision. And when I actually sat down to talk to my mother, she looked at me and she said, "You are my baby, and I could never kill you." She was telling me she couldn't do it. So I turned to my father, and I thought, there's no way. My father is really sentimental. He was very emotional. I didn't think he could get through a conversation with the doctor if there was bad news involved. But he looked at me and said, "You've shared with me what's important to you. If that's what you want, that's what I will do." So he became my decision maker. So it's really important to have those discussions to figure out who can actually represent your wishes for you the best. And then to talk with them about what your desires and beliefs are. Now, that doesn't mean going through scenario after scenario. If I'm in a car accident, if I have heart disease, if I have a heart attack, because we can't predict what's going to happen to us. But talking about your values. If I can't go hiking anymore, if I can't hug my grandchildren, if I can't work, if I can't read a book, if I can't watch movies on Netflix, whatever is important to you that gives your life meaning, that will help your family make those decisions on your behalf. And then you can also specify your beliefs about organ donation, whether you want to be a donor in full, in part, can also be specified in an advance directive document. Next. There are a lot of different forms. I've given you some examples here. You'll see over on the far right, that is the official California form, fillable online. It's probably the briefest and easiest document. There are other forms. The one that with the blue header that says California Advanced Healthcare Directive is a simplified form, larger print and pictures to walk you through step by step what decisions you need to document in the document. And then the 5 wishes form is an example of another kind of form that really delves more into your values and what is important to you to provide guidance to your family. So lots of different ways you can do this. Frankly, in California, you could scribble your wishes down on a napkin, and as long as it is witnessed or notarized properly, it will count as your advance directive. What's important with that document is what you do after you have completed it, that you've talked to your family about what your wishes are, that you've helped them understand why you chose the decision maker you chose, and that the document is available. I've seen people stow them away in their security box at the bank or a home safe or in files among other important documents. If we can't find it, we don't know and don't know what it says, we can't honor your wishes. So it's important to have the discussion. So even if we can't find the document, your family knows what you want. Next. The gift of advanced care planning. We should talk about our final arrangements so the kids aren't burned with it. Why should we care? That'll be their problem, right? Well, at least we talked about it. And while this is a joke, unfortunately, that may be the extent of the conversations people have. I would argue that sharing your wishes with your family is the greatest gift you can give them. I have spent a lot of time in the waiting room, outside of the ICU, outside of the patient in the hospital bed's room, talking to families about what their loved one would want. And so often they have no idea. And now here they are in a highly emotional situation, under pressure from the healthcare team, from the physicians, to make an impossible decision, which would be so much more possible if we already knew what the patient would want. If we were implementing that person's wishes instead of having to figure them out in that kind of situation, it would relieve a great burden for most of us. So next. So if you can't laugh about something, all you're going to do is cry. So I wanted to share some things people have actually put into their advanced directives. There are some really good ones out there, and it always inspires me to be more creative in my own. In the event I become permanently unconscious, keep me alive long enough to determine if the Dodgers have a shot at the World Series. If not, life is no longer worth living. Another patient wrote, if my husband and my father fight over medical decisions for me, remind them that neither gets to decide. I appoint my best friend, she listed the name, as my power of attorney. If I am no longer able to ask for chocolate or swallow good wine, it is time to pull the plug. She was very clear about what gave her life meaning. I refuse any treatment that will deplete my children's college fund. I request that all treatments be tried to assure I die in particularly dramatic fashion. I'd like Lady Gaga to play me in the movie. So I think now I am able to take your questions.
Thank you, Dr. Cohn. That was amazing. Thank you so much. Yeah, we do have some questions from the audience. Let me engage you in a little conversation first.
Okay.
First, just your talk reminded me of so many things in my life, and it reminded me that, I don't know, maybe it was 1984 when I was taking a class in bioethics. I actually used a quote from Gulliver's Travels in my term paper. I was like, I'd totally forgotten that, and it also reminded me. I did my philosophy graduate work at USC, of all places, and I had a friend who's probably not watching tonight, who was an immortalist. And you might enjoy this. You might be able to use it in your work, because he had this way of turning the tables that anybody who accepted their death, he labeled a deathist. Oh yes, yeah. I like to engage you deathists in with, in intellectual conversation, and try to persuade you to be an immortalist. That's not going anywhere. These are things that I was reminded of.
I think you'd be fascinating to talk to.
Oh, he's a really interesting guy. Yeah. Yeah. One of some of these questions I don't know quite where they're going, so you can interpret them broadly. But I think for many of us, some of the most tragic stuff in this COVID experience is the patients dying alone. And but I've really just heard about it through the media and whatnot. I haven't experienced it. So I wonder if you have anything to say about that. But I've also heard talk that some hospitals regretted separating the patients because they felt that they were coercing families. That, I don't know any of the data, but they said that families are more willing to essentially pull the plug or let go because it would be quicker actually be with their parents or whoever it was. I'm not sure if you heard that claim, that some people are worried about that.
Would it be quicker to be with them if they had passed away?
Yes, essentially. And so the doctors had worried that they were essentially coercing family surrogates to make decisions they wouldn't have otherwise made.
I haven't seen that. In fact, I've seen the opposite.
Oh, well, tell me what you've seen.
Well, it's been really difficult for families because it's not real. You don't see your loved one in the hospital bed suffering. So it doesn't seem real. And you get the phone call from the doctor or the nurse every day who tells you what your loved one is experiencing. And it's hard to believe that, mom is having that much trouble breathing, that mom's needed all these medications to keep her blood pressure up, that mom's kidneys are failing and now she's on dialysis, because you don't see it. And even taking the iPad into the unit and FaceTiming with the families so they can see their loved one, it's still not real. It's like one of those characters on the doctor shows on TV. It's not really my mom. And these families have a really hard time making those decisions about end of life because it is so unreal. They want to see it in person. And so the visitation policies have been really strict, for good reason, because of the infection risk.
Yeah.
And because of the limits in, of PPE, of the personal protective equipment, to keep everyone safer. And so we don't know what people are carrying into the hospital, and we need to protect the healthcare professionals so they can continue taking care of all the patients. So there are good reasons for those limited visitation policies, but it's been really hard on everyone. We can't see our loved ones as they're dying. We can't be there to hold their hands. We can't visit every day like we normally would. So the patients are feeling isolated, those who are awake and alert. And it's hard on the clinicians too. The nursing staff will depend on family members to come in and help take care of the patient, to keep the patient in good spirits, to be there. And they don't have that to rely on. The physicians too, would prefer to talk to you in person. So you come to visit your loved one and they'll come talk to you face to face and tell you what's going on, and they can show you what they're seeing. But now they're doing it on the phone. And if you consider, a busy ICU unit with even just 10 patients, if you spend 10 minutes on the phone with each family, and it's never that short of a phone call, 10 times 10, that's already 100 minutes of time you're spending on the phone instead of providing direct patient care. So these visitation policies have been really hard on everyone. And I don't know, I know families feel it. I don't know if they recognize how hard it is on the staff as well. We do have exceptions to the policies. If you have a child in the hospital, we usually allow a parent to stay, and now we'll allow the parents to alternate. If you have a wife or a woman who's in labor, their partner can often be with them, not for a C-section, not for a surgical procedure, but they can be with them during delivery, but no one else. So grandma who's been waiting to see that baby doesn't get to meet that baby when the baby's first born, and because they can't sit in the waiting room and wait to see the baby, they're just not allowed in. And we do allow people in for end of life. And in my hospitals, at least, we have started letting people in when we're asking them to make those decisions so that they can see for themselves. That becomes hard too, because there's no context. You haven't seen them every day. And so a little twitch for a patient who we think is unconscious and going to remain that way can be really meaningful to a family without the context and understanding that it's involuntary.
Yeah, that's tough. And I don't think we hear enough about, how this does impact the staff as well. Yeah, we hear about so much more. I have some other questions, but the phones are really lighting up. And I see a colleague of mine, Dr. David White, who teaches the religious conceptions of death. I don't know if you can see the Q&A, because he's an academic, so his question is really long. That's what we do for a living.
I don't think I can see it.
But if you go to the Q&A thing, you might be able to see a super long message. I'll try to read it. It says, hi, Felicia. Thank you for a stimulating talk. Here at UCSB, I'm the instructor of a large lower division course. Hopefully, some of my students are attending. In 2005, I inherited this course from another professor who grounded his course in Elizabeth Kubler-Ross's work, an approach that comes closer to your work, as I understand it, than my own, which is more anthropological, historical, and comparative, and treats many of ritual belonging to the living and afterlife of the dead. So to come to my question, yes, thank you, David. Come to your question, which concerns the issue of playing God. This is an assessment made by historians concerning the Catholic Church, which in the 13th century effectively invented purgatory and placed itself between sinners and God in matters of salvation. Since instead of God determining who was to be saved, the church could be overturn the sentence of the sinners of sinners who would otherwise have suffered eternal damnation. And then he goes on, if they were offered by the faithful on their behalf. How does the afterlife factor into the way people play God by seeking to provide life artificially? This would only apply to people of faith who theoretically comprise at least 2/3 of the US population. Does their faith impact their decision about whether or not to play God by artificially prolonging life through medical intervention?
That's a really fascinating phenomenon. I've joked before that I think God lives in the hospital because people seem to find him there. People who haven't been religious or, religion in name only suddenly are much more spiritual and devout than they have been previously. And, I get that. They are praying for their loved one to survive, to recover, to return to them. I think what this does is actually encourage people to continue treatment, to continue that fight. I've had a lot of patients' families tell me that it is contrary to their religious beliefs to stop treatment, which I have not seen in any religion at all. There's no mention of ventilators in the Bible, and there's no obligation to accept certainly supererogatory treatment and even ordinary treatment. There's no obligation to accept. Yet, families will often drop that argument on the healthcare team, and it's a conversation stopper. The physicians don't feel comfortable challenging somebody's religious beliefs and will act on those beliefs. And I've always questioned, if you really believe in God, believe in a heaven, why would you not want to get there? Especially if there's immense suffering here on earth for your loved one, who's not expected to survive, who may be the best that we can hope for is life bedbound, machine dependent in a nursing facility. So it's always a confounding conversation for me to really understand what people mean and how they evaluate their religious beliefs in this context. And the misunderstandings, when with Pope John Paul a number of years ago when he was dying, and he opted to have a feeding tube. And he was very clear that this was a personal choice. This was not a religious decree. He wasn't mandating that everyone accept feeding tubes. But the patients I had coming in after that, who, when the physician suggested foregoing a feeding tube for their loved one, were mortified, saying, "Oh no, I'm a Catholic and we can't starve mom to death." And it was a complete misinterpretation of the religious beliefs, yet these were deeply held or felt beliefs for that person, for that family. So challenging those in a medical context is a really difficult conversation. I don't know if I answered your question, but I tried.
We'll go out for cocktails afterwards. The conversation. Let me ask a question, but there are a number of questions coming in. I have friends who are doctors, and they tell me, and they tell my class, they say, as a doctor, I could make you do just about anything, when I'm wearing this white lab coat. We talk about that in, informed consent and that kind of stuff. And when I'm teaching about like active euthanasia, this is going to the stuff about choice, and the expansion of choice, and that death is in many ways or is perceived to be more and more of a choice. And so I feel kind of the same way. I feel that as a teacher, if I felt like it, I could probably convince 100% of my students to endorse active euthanasia. I mean, they are so open to autonomy, right? That's the value, that's the thing. And I know this is a very long conversation, so I'm only asking for a short answer because we go on all night on this one. Do you have any words that might warn us away from active euthanasia, or alternatively, do you see us moving in that direction?
I don't actually see us moving in that direction, at least not anytime soon. I think while we do prioritize autonomy, we also value the sanctity of life, the sacredness of life, in ways that really would overwhelm those arguments from autonomy. There have been some inroads, physician aid in dying or physician assisted suicide, has been legalized in a number of states. And I do see that kind of sweeping the country, becoming more of the norm rather than the exception. But that still maintains the agency of the individual who's taking their life. It doesn't impose an obligation on others to respect somebody else's autonomy. Mm-hmm. And I think that's the key distinction. So I don't see us moving, and I'd be worried, actually, I think if we did, I have concerns about legalized physician-assisted suicide or aid in dying as well. Active euthanasia, legalizing that, really legalizing a form of murder, I think would be incredibly difficult to protect and could lead to a number of abuses that they have seen to a limited extent in the countries where it is legal. But I think would be more problematic here because we don't have a uniform culture or belief system.
Okay, I'm going to take a few questions from, it looks like mostly students. One student asks, first, what would you say, it's about the relation between socioeconomic status and being taken off life support, if there is a connection. But then she says, which leads me to my next question on your opinion, in your perspective of this, what the steps that should be taken in beginning to resolve inequalities within the health field that would result in a disproportionate number of deaths that have exemplified in the pandemic in relating to financial accessibility. So I guess.
Wow.
Yeah, that's a kind of a big
that's one. A whole other lecture.
Yeah.
With regard to taking people off life support, I don't see disparities. I mean, I don't know the data, but I don't see disparities on an individual case-by-case basis. When I see physicians make the recommendation to transition to comfort care, to stop life support, or to not offer life support, it has nothing to do with who the patient was and everything to do with that patient's condition at that time. Now, underlying all of that, of course, is that there are people who get a lot sicker because of their socioeconomic conditions, because of their social class, because of their ethnicity, their culture, their background. And that all gets played out, in the ICU, unfortunately. But I don't see it as an issue on a case-by-case, patient-by-patient basis. How to even begin addressing the disparities, that's work for our society to do. We have to start really taking seriously what it means to have equal access to healthcare resources, what it means to have equal access to all resources, and how we balance those things in our society. There's some really great philosophical work, I guess. John Rawls' Veil of Ignorance is probably one of my favorites. And I challenge people to think that way. If we were behind a veil of ignorance, if you really didn't know what you were going to be in society and had to make decisions, what decisions would you make? And would they look different from the decisions you make, knowing who you are and how you're situated in reality? And I suspect for most of us, the decisions would be very different. We would divide our national pie, our resource pie very differently if we didn't know what part of it we were going to get.
Yes. Yes, that sounds fair enough. Okay, I'm taking up another question. In a recent video in the New York Times had ICU nurses wearing body cams. Have you seen this?
I haven't seen that.
Oh, well, if you don't want to answer the question, you don't have to, but it is actually quite astonishing. I can send you the link. Wearing body cams to show not just what the patients were like, but what the nurses were dealing with, what the nurses really were going through. So the question is, what is known about how healthcare professionals' attitudes towards death have changed in the COVID world?
I don't know that their underlying attitudes have changed. I think they've been exhausted by seeing it so much more. You know, it used to be, it's an unusual event when someone actually dies in the hospital. I mean, it happens all the time, so it's not uncommon, but it doesn't happen in the same unit multiple times in the same day. And I've had mornings when I've shown up for rounds and it's really somber because 4 patients have just passed away. And I think seeing it so much more has reminded these healthcare professionals of what it is they're actually doing. And at the same time, has just completely emotionally and physically exhausted them because they are spending their time trying to prevent it from happening. And it's in so many cases just seemed like a futile battle. So I haven't really dug into their feelings to understand if their personal beliefs about death and dying or their professional beliefs have changed. I don't think they'll even be ready to talk about that for months. And there's going to be a lot of PTSD.
Yeah. Yeah. Thank you. Here's a very quick one. Dr. Cohn, do you believe it's healthy for us to meditate on our own mortality?
I do. I think recognizing that our time on this earth is limited helps each day feel more meaningful. So I don't see it as a negative. I don't see it as doom and gloom, worrying about our mortality. I see it as appreciating what we have now. We're less likely to waste our days if we know that they're limited.
Right. Okay, thank you. Let's see. Have you seen differences in end-of-life choices between religious and non-religious people? This takes us back to Elizabeth Kubler-Ross. You mentioned people finding God in the hospital, but are there people who go in the other direction?
There are people who, sort of the theodicy question, if God is good and powerful, then why is he letting this happen? Why did bad things happen to good people? Kinds of questions, questioning faith, giving up faith, because if God really cared, he wouldn't let this happen. So yeah, I have seen it go the opposite direction as well, but it doesn't mean they're any more willing to let go.
Right. Right. This question takes us back to physician-assisted suicide and whatnot. We've discussed that already a bit, but I guess there's a twist. Would you be more comfortable implementing, such policies, whether active or assisted suicide, if the U.S. health system was more similar to, well, it says here EU countries, well, any other developed country in the world, where we had universal health care?
I don't know. I think it would make it easier if we were a more homogenous society with universal access to healthcare. I think it could be another limit we could set. And I do think it has worked reasonably well in other countries. There's still services that are not well utilized. There aren't high numbers of people dying from active euthanasia or assisted suicide in any country. But I just think it's something we need to be really careful about.
Yeah.
In this culture, I don't know. There are just too many. We run the full gamut along the continuum about our beliefs of the value of life. And it'd be really, I think, to implement that kind of program.
Okay, here's another question from a student. Do you have any suggestions for how to start conversations about end-of-life plans with loved ones who aren't ready to confront their mortality?
That's always hard because old is always at least 20 years older than you are. So convincing someone, I think at some point a switch flips and we're more willing to recognize our mortality. But I have had patients in their 90s who still aren't ready to talk about it. It's just too hard, too personal, too emotional. I think sometimes turning it around and helping that person understand how it will help you can help them. Mom, I don't want to have to make this decision for you. I want to know what you want. And make it about choice and not about dying can help. And then, that guilt card that all children can play with their parents can help sometimes too. Please help me help you. I can't bear this burden myself. I can't do what you want if I don't know what that is. I can't honor your wishes if I don't know what they are. But there are a lot of folks, more experienced at this than I am. There's a whole project you can find online called the Conversations Project that has lots of good conversation starters. It was a reporter, a syndicated columnist, Ellen Goodman, who started this when she was reporting and realized how hard these conversations were. And she wanted to make it more about conversation. So there's now a whole website set up, and they have, great advertising campaigns and conversation kits. They've started another, like a spin-off of that called Death with Dinner, where you actually have dinner parties where people will discuss their end-of-life preferences, fill out advance directives together. So, those are some ideas that might help normalize it. There's a community in La Crosse, Wisconsin, where you are an outlier if you don't have an advance directive. Now, it's a small, relatively rural community, but they have just normalized advanced care planning and made it part of what everybody does. And we've tried as a society to do this. We've made advanced directives available. We've started life care planning programs. People just still, don't do it. But there are a lot of inroads there. When I started doing research in this area, less than 20% of people had an advance directive, and now we're in the mid-30s. So it's gone up a bit. We've gotten a lot better with providing hospice care, palliative care. So there are more resources out there, and to help remind people that dying doesn't have to be miserable. It can still be a meaningful time if we choose to make it that way.
Right. Another thing your talk maybe reflect on is, when my father was confronting his mortality, and he had dementia at this point, and but he was reflecting on, he's quite open about talking about it. And I think we have these two, well, we have many different conceptions of death, but two that keep bumping into each other are the that we think of lost future experiences, sort of the economic model. I'm going to lose out on future experiences. And then there's the sort of discontinuation theory that my continued existence simply stops. And my father inadvertently summed this up really neatly when he said to me, Greg, if you told me I'm going to die on Wednesday, I don't have any problem with that. I've had a full life, et cetera, et cetera. Yeah, okay, Dad, And then he says, but just not just at the moment.
Mm-hmm.
And the point is, he would probably repeat that on Wednesday.
Right.
I'm not sure if this is a question. Let's see. I have a question here. It needs interpretation. You had made some comments about changes in attitudes with younger people, and we'll have to see where that goes. But this question seems to be pointing to data that Gen Z is facing higher rates of depression and suicide. I'm not sure how the question fits in, but do they perhaps have a more schizophrenic attitude towards death, or?
Yeah, that I don't know. I haven't seen data on Gen Z, and I don't know if that's current data. Does it reflect the current experience of the pandemic and the social isolation and all of the things that are being stolen, all of the experiences? Speaking of opportunity costs, the opportunity costs of this pandemic are, tremendous. All the things we've missed out on. And, for adults, we've experienced a lot of things. And so, yeah, this has not been a fun year. And there are a lot of things we've missed. But we can reflect on those previous experiences. When you're younger, you don't have as much to reflect on.
Yeah.
When you're still in school, there's, and all that's been taken away, it's so much harder, I think. And I look at even the real little ones, the 4-year-olds who aren't ever going to remember not having to wear a mask. And what is that going to mean if and when we come out of this? And or are they going to feel naked without them? So yeah, I don't know much about Gen Z, but yeah, I think the attitudes toward death are evolving, and I can't help but think that this pandemic is going to change that, particularly for younger people.
Okay. We probably don't want to take the full 90 minutes, so I want to take just maybe 2 more questions. One we touched on a little bit, but maybe we can give it a different spin. Do you see healthcare workers losing their humanity and empathy over constant PTSD?
No. If anything, I think it's been reinforced. They may be too exhausted to always demonstrate their care and compassion, but I think they've been able to empathize even more because a lot of them have experienced this illness themselves or have had family members experience it. They've been thrust into these situations that they wouldn't normally have to be in. And that experience, I think, when they actually come out the other side and get through this and reflect on it, will probably make them better clinicians, more compassionate. But it's going to be hard fought. There are so many people doing in roles that they wouldn't normally be in. We've had pediatric nurses in adult units because we just needed more hands. We've had family physicians, pain specialists who are in COVID ICUs because we needed more physicians. And I think they've all expanded their view of what medicine really is. So I think it has maybe helped them, as painful as it's been to get there.
Okay, thank you. Maybe I'll try a question myself, because I'm always wondering about this stuff about death and choice, and at least I don't know what the future holds, but it looks like in the past our choices have just sort of increased, right? and whatnot. I don't know where we're going, but some people have worried. I mean, when we're in these situations, I mean, we want, we hold on to our loved ones, especially our children, right? But the opposite sort of phenomena happens when, because, dying is sad, it's many things, but it's also boring. It takes, you're sitting weeks, whatever, in a hospital, eating hospital food, which is quite good at our local cottage hospital, by the way. Many people experience what Patricia Mann calls these our secret desires, that we say, oh, can't you just go ahead and die, Dad? This is really getting long, and what's the point of it? And then she says, well, we feel kind of embarrassed after after we, have those thoughts, those thoughts come to it and go, well, we often have thoughts that we regret. But some of her reflection was on the possibility of legitimizing those desires, that, if we become more open to death being a choice, there might be more normalization of the choice, and that might, if you like, normalize those secret desires, that they're no longer something to be embarrassed about, but something to be openly discussed. I mean, we're it's kind of lofty way in speculating about the future. I don't know if you have any thoughts about that.
Yeah, I see among the families I work with a lot of guilt and a lot of relief when someone finally does pass. And, all of those emotions are completely legitimate. For most of us, the data I shared, we're likely to slowly dwindle. That's, that double-edged sword I was talking about of increased longevity. We live longer, we get to experience life longer and have so many more wonderful experiences, but we're doomed then to suffer before we go, unless we're one of the fortunate ones who really does die in our sleep, or around here we cross a street at the wrong time and get taken quickly in an accident. It is a gradual dwindling down, and we adjust. So what would seem really boring to me now might not be in that situation, because we do adjust and adapt. And our families do too, to a certain extent, but the more I dwindle, the more my loved ones have to care for me. And that itself is exhausting. So I've seen family members who've taken care of their loved ones for months or years. And when they feel that relief, the dad's finally gone, because now I don't have to get up every morning and bathe him and dress him and feed him. And, I can go back to work. I can see my children now that I have time to see them, so they feel that relief. And I think that's fair. But the guilt they feel because they feel relief can be overwhelming. So I think if we can normalize dying and death and accept it as part of life, then we can appreciate that time more and not feel guilty. It also speaks to the inadequacies of our healthcare system, that we don't have support for those things. None of that caregiving is supported. There are, well, to a very limited extent, there are caregiving dollars available to patients who are on Medicare, Medicaid, and there are, caregiver services, but they're very limited, and we don't pay these people well. So it's hard to find people to help. So for most families, living with someone with a chronic progressive illness, it is exhausting. So yeah, all of those emotions and the boredom too. It's all very, we need to find a way to make the final phase of life more meaningful. And that, I think, is one of the biggest challenges, dying as a public health crisis.
Great. Well, thank you. I think this is a good place. That's a good note to end on. There are more questions, but I think you've answered the really important ones. And this is where we would, in a normal year, I'll stand up and give you a great round of applause to Felicia Cohn for this, sharing these wonderful ideas and perspectives with us. We don't even have the little fake hand clap function I see, but I'm sure that everybody has really enjoyed and appreciated this very frank discussion, and so and we at the CAP Center certainly would want to thank you very much, and we hope to have you up to the real Santa Barbara sometime very soon.
I hope so. And thank you all very much for having me. Like I said, I wish I could see your faces. I get to meet you all, spend more time in post-lecture discussion, talking about all these interesting things. So I do hope to have that opportunity. I'll note I have a daughter who is looking at applying to UCSB.
Yeah.
We'll see. We'll see where she
All right.
ends up.
Let me know. Let me know if that happens. Okay, so thank you again, and everybody. There's 2 more CAPS events this week that are in the chat, or check out our webpage or our Facebook page, or the Walter H. CAPS Center. Thank you all very much, and good night.
Thank you all.